Now we'll talk about an important topic in the nervous system, which is the meninges, dural spaces, and types of dural hemorrhages. So what are the meninges? The meninges, like the wrapping paper, 3 layers of wrapping paper that is found around the brain in the skull and around the spinal cord in the vertebral canal. So the brain and the spinal cord are very, very special and precious gifts from God to mankind. And every human being wants to protect this very precious gift, the central nervous system. So the brain and the spinal cord are wrapped in 3 layers of gift paper, if you will, and these layers are known as the meninges. And these meninges that cover the brain also extend downwards to cover the spinal cord, as both are contained in the bony compartment, the skull for the brain and the vertebral canal for the spinal cord. There are 3 layers of meninges, and they are from without inwards: the dura mater, the outermost layer of meninges, that is just in contact with the skull, and the innermost layer of meninges that is in close contact with the brain is the pia mater. And you notice the name. Mater in Latin means mother, dura means tough, and pia means delicate and tender. And because the pia mater is in close contact to the brain, so it has to be very tender layer, sensitive layer, full of pain receptors. Whereas the dura mater, the outermost layer, in contact with the skull, and the skull is bony, so the dura mater has to be tough and strong. In between these 2 layers of meninges, we have the arachnoid mater, and the name arachnoid means it has villi, and these villi serve to absorb the cerebrospinal fluid, as we are going to explain in a moment. So the presence of 3 layers of meninges create 3 dural spaces. The first dural space is outside the dura mater, that's to say between the dura and the skull, and is known as epidural space or extradural space. And that's a potential space, meaning that it does not have any fluid inside, just blood vessels, arteries, and veins. And then the second space is the subdural space, another potential space between the dura mater and the arachnoid mater. And the third space is the subarachnoid space. And this is the only true space because it is filled with the cerebrospinal fluid. And this space is between the arachnoid mater and the pia mater. The cerebrospinal fluid is produced by the 4th ventricle in the brain, and it circulates and fills the subarachnoid space, and it serves a cushion-like effect or function to further protect the brain. And this cerebrospinal fluid is drained via some villi that come out of the arachnoid mater, hence the name arachnoid mater. So the 3 spaces, the epidural space, the subdural space, and the subarachnoid space, they have blood vessels, arteries, and veins. So let me draw. So in the epidural space, there are arteries and veins. Subdural space, there are arteries and veins. Subarachnoid, arteries, and veins. And let me use blue color for veins. So if any one of these vessels is injured or ruptures, so let's start with the epidural space. What do you call it if one of the blood vessels in the epidural space, for some reason, ruptures, trauma or something, and blood comes out and accumulates in the epidural space or extradural space. We call this condition extradural hemorrhage. So extradural hemorrhage can result from arterial bleeding or venous bleeding, but most of the time, the cause of extradural hemorrhage is arterial bleeding. By the same token, if a blood vessel in the subdural space is injured, we get subdural hemorrhage. Again, subdural hemorrhage can happen as a result of arterial bleeding or venous bleeding, but most of the time, subdural hemorrhage results from venous bleeding. What about the subarachnoid space that has CSF, arteries, and veins? If you have vascular injury in the subarachnoid space and blood accumulates in the subarachnoid space, we call this subarachnoid hemorrhage. So what is the major source of bleeding in subarachnoid hemorrhage? Is it arterial bleeding or venous bleeding? Actually, it is arteriovenous malformation. Arteriovenous malformation. Which is abnormal connection, direct connection between the artery, the high pressure vessel, the thick wall vessel, with the vein, the low pressure thin wall vessel. And as a result of this abnormal connection, you get projections or dilatation of the vein, of the venous wall, what we call perianeurysm. And any one of these small, tiny dilatations, any one of these perianeurysms can rupture out of the blue. And when it ruptures, it usually results in subarachnoid hemorrhage. Now let me go through these three types of hemorrhages, and let me start with the extradural hemorrhage. Let me use the whiteboard to talk about extradural hemorrhage. So extradural hemorrhage occurs between the dura, which is the outermost layer of meninges, and the skull. And it usually results from arterial bleeding. Most of the time results from trauma, head trauma. And actually, the weakest part of the skull is this part of the skull bone, kind of the temporal area. And trauma to this part, when you get fracture or trauma to this part, we have an artery that runs in the extradural space here, and it's called middle meningeal artery. Middle meningeal artery. This is the artery that usually, that's the most artery liable to get injured with head trauma, because this is the thinnest part of the skull. So what happens when you get trauma to the skull? Any head trauma will result in concussion. Concussion means the brain is going to shake inside the skull because of the forces of trauma, the acceleration, deceleration forces. The brain is going to shake inside the skull. This happens in any head trauma. In any head trauma, you get concussion. And classically speaking, a concussion should be associated with loss of consciousness, brief, reversible loss of consciousness, even if it is for 1 second. So the first stage of head trauma is concussion. And the patient loses consciousness anywhere between 1 second up to 6 hours, and then the patient regains consciousness spontaneously. Usually, the loss of consciousness is around 1 to 2 minutes. Usually, it's a few minutes, very few minutes, short minutes. After that, the patient regains consciousness. So the first initial loss of consciousness is because of concussion, and then the patient regains consciousness and remains conscious for an interval of time known as the lucid interval. So during this lucid interval, the patient regains consciousness, but what's going inside? A middle meningeal artery is injured and arterial bleeding comes out. And by the way, arterial bleeding is serious, more dangerous than venous bleeding, because venous bleeding occurs kind of slowly. So even if we have a hematoma developing because of venous bleeding, this is going to take time to develop. But in arterial bleeding, this hematoma is going to reach big size in a relatively short time. And this is what happens with the extradural hemorrhage. Arterial bleeding accumulates rapidly in the extradural space, creating extradural hematoma. And this hematoma will increase the intracranial pressure and will press on the brain, and this will lead to loss of consciousness. But this time, this loss of consciousness is going to be kind of terminal loss of consciousness. So you are going to get loss of consciousness again due to increased intracranial tension. And because of this scenario, so if we know this scenario, we will recognize that any patient who gets head injury comes to the ER because of head injury, especially if it was associated with loss of consciousness, brief loss of consciousness, should not be discharged unless you make sure that there is no hemorrhage inside. And the best test to detect intracranial hemorrhage is CT without contrast. CT without contrast. Why? The contrast looks white on a CT scan, and the blood looks white on a CT scan. So you should do CT without contrast to exclude the presence of extradural hemorrhage. Moving on to the subdural hemorrhage. In subdural hemorrhage, which is usually the source of bleeding is usually venous, and venous bleeding is slow bleeding, less dangerous than extradural hemorrhage. The typical patient with subdural hemorrhage is an elderly who will be brought to your office or to the ER with this by his grandsons or by his sons, by his children, and they will say, we don't know what's wrong with our grandfather. He seems to be quiet these days. He does not talk. If we ask him a question, he takes time to answer. He sleeps too much, and there is something weird about him. And you check by CT and you find huge hemorrhage in his skull. So usually elderly have some sort of brain atrophy. So they have a big space in their skull to allow and accommodate big volumes of venous hemorrhage. And this venous hemorrhage happens because of venous injury, maybe very slight, very mild head injury that they even forget, but because their vessels are fragile, so a vein is injured. And because this is a vein, so it's a low pressure system, especially if they are standing or sitting, the veins, the pressure is even less. So the bleeding out of this vein occurs very, very slowly and very gradually. And the brain atrophy allows the space for this bleeding to reach a big size, and this is usually the picture in subdural hemorrhage. Now, the third hemorrhage, the third type of hemorrhage, which is the subarachnoid hemorrhage. Subarachnoid hemorrhage is rupture arteriovenous malformation. So usually, if this is an artery or arteriole, this will be the venous wall, the vein. And usually in between, we have this set of capillaries. So this set of capillaries allow for pressure reduction between the artery and vein. So the pressure here in the artery is like 90 millimeter mercury. That's the mean arterial pressure. And the pressure in the vein is like 5 to 10 millimeter mercury. And the wall of the vein accommodates this pressure. Now imagine if the artery and vein are in direct continuity. If you have an artery here and it continues as a vein, and the vein starts right away without any pressure reduction capillaries between them. So the vein will be subject to the high pressure that is in the artery. But the high pressure cannot damage the arterial wall because it is thick. But here, when the venous wall is subject to this high pressure, it will start to bulge, outward bulge like this. And it happens at different points close to each other. And it looks like berries. This outward part, pouch is known as aneurysm. So that's known as berry aneurysm. Berry aneurysm can rupture at any moment. It's like a timed bomb. It can rupture at any moment. And of course, when it ruptures, huge amounts of blood will accumulate rapidly in the subarachnoid space. Now, the subarachnoid hemorrhage, because it occurs very close to the brain, very close, it will be in 50% of cases will be associated with loss of consciousness. In the other 50% of cases, there is no loss of consciousness, but what is going to be there? The subarachnoid hemorrhage is the closest hemorrhage to the pia mater, to the innermost layer of meninges, the most sensitive layer of meninges. And this irritates the pia mater, which is very, very sensitive. So you get severe pain in your head. What do we call it? We call it headache. This headache is very acute, actually very, very abrupt onset. And very, very severe. Patients describe it as worst headache in my life. And because it hurts a lot, especially if you move your head. So these patients will make sure that they don't move their heads, and the neck muscles will become stiff. So that's neck rigidity. Neck rigidity. And with the subarachnoid hemorrhage, you get fever. Because after all, subarachnoid hemorrhage or any hemorrhage is some sort of tissue damage. And with tissue damage, the body responds by inflammation. And one of the systemic manifestations of inflammation is fever. Also, the accumulation of blood, this also results in fever. So these are the major symptoms of subarachnoid hemorrhage when it is not associated with loss of consciousness. We have this triad of headache, neck rigidity, and fever. Does this ring a bell? Headache, neck rigidity, and fever. Do these symptoms sound like meningitis? Yes, they do. So what's a differential diagnosis of subarachnoid hemorrhage? Is meningitis. Both of them present with the same symptoms. Both of them present with the same symptoms. So the first step when you have a patient who comes to the ER complaining of headache, neck rigidity, fever, it could be one of the 50% patients who do not lose consciousness with subarachnoid hemorrhage, or it could be meningitis. How to tell them apart? The first step is CT without contrast. CT without contrast to exclude subarachnoid hemorrhage, to exclude or confirm the diagnosis of subarachnoid hemorrhage. Now, if you exclude subarachnoid hemorrhage, you have not yet confirmed the diagnosis of meningitis. So what to do to confirm the diagnosis of meningitis? We do lumbar puncture and get a CSF sample and analyze it. Now, meningitis is usually bacterial infection. The cause of meningitis is usually bacterial. So if you have bacterial infection involving the meninges, you expect to have a lot of white blood cells in the CSF. So the first thing you expect to find is elevated white blood cells in the CSF. Leukocytosis of the CSF. That's the first thing. And these microorganisms, any microorganism is made of protein. So when you have hundreds and thousands of protein cells circulating in your CSF, you will have increased protein content of the CSF, increased protein content of the CSF. And these bacteria eat, they feed up on the glucose in the CSF. So the third finding will be low glucose level in the CSF. So this is how you diagnose meningitis. And of course, when you confirm the diagnosis, you start treating by antibiotics. Actually, sometimes we start giving antibiotics once we suspect. We start giving the first dose of antibiotics, even we just take the blood sample for a blood culture and then give the antibiotics, one dose, and then send the patient for CT without contrast. And when they come back, we do the lumbar puncture and we confirm the diagnosis and we continue the treatment so as not to delay the start of antibiotics. So this concludes the discussion of the meninges, dural spaces, and the different types of hemorrhages, extradural, subdural, and subarachnoid hemorrhages.